Good morning, everyone. My name is Shweta Kambali. I am one of the PGY1 interns from Central Michigan University. On behalf of my team, I would like to thank you all for giving me an opportunity to present this abstract. And we would like to highlight few signs and about aspirin toxicity. So, a little bit of background. Salicylate toxicity is a medical emergency that requires us to diagnose it early on to prevent any lethal complications. Although we have seen a decline in number of salicylate poisoning, it still accounts to approximately 30,000 cases per year, out of which nearly 53 result in death. And aspirin is one of the most commonly prescribed analgesic as well as antiplatelet agent for all the cardiovascular and cerebrovascular diseases. Also, I would like to mention that wintergreen oil is one of the non-pharmacological agents which has high levels of salicylates. So, talking about our case report, so a 73-year-old female with history of multiple back surgeries, chronic back pain, who was on pain medications with Norco, gabapentin, aspirin, and acetaminophen as well. She initially presented to the ED in one of the outside facilities where she presented with nausea, vomiting, and abdominal pain. She initially just received conservative treatment, was given Zofran, and sent back from the ED. The next day, she comes to our hospital with altered mental status. And on our examination, she was tachypneic. She was hypotensive. When we examined her, her pupils were normal in size and they were reactive, which right away we ruled out any signs of opioid toxicity. And then neurologically, she was alert and oriented times, I would say 2, and she was able to follow commands minimally. Respiratory wise, she was just tachypneic, but otherwise there were no signs of any aspiration, pneumonia, and cardiovascular wise and abdominal examination were totally normal. In our chance, we were fortunate to get more history from the husband, where he told us that she was taking excessive medications, as up to a point where he was actually hiding medications. When we ordered some labs, initial ABG showed a mixed picture of respiratory alkalosis and metabolic acidosis. And since we got more history, we checked for aspirin levels, which initially was very high at 69.7. And the therapeutic levels are usually around 10 to 30 milligram per DL. She was also noted to have AKI due to this toxicity, and CT scan was initially negative, but when we did an EAG, it showed us signs of metabolic encephalopathy. And of course, due to this chronic picture of aspirin toxicity, her liver was affected, and that's why her prothrombin time was elevated, but we did not see any signs of active bleeding. So a multidisciplinary team was involved in a care where with an intensivist on board, neurologist, and a nephrologist on board. We initially treated her with just bicarbonate drip to alkalinize her, but then she continued to show worsening signs of her mental status, and that's why within 24 hours of the admission, we started her on dialysis and also started her on Keppra to prevent any seizures. And on day 2 and 3, she actually improved. There were signs of rapid improvement. Her EAG was normalized, and her pH, as shown in the table, after hemodialysis, metabolic acidosis was almost resolved. There was slight residual of respiratory alkalosis. AKI hypokalemia was resolved as well, and aspirin levels were down to 2. So, what are the common risk factors? Old age, women are at higher risk of developing salicylate toxicity, and of course, people with high BMI and cardiac tissue disorders because they get aspirin prescriptions. And racial disparities also do exist in these cases. In fact, non-Hispanic African Americans and Mexican Americans were noted to consume less of NSAIDs. So what are the effects? Basically, we see initial signs of nausea and vomiting. It's basically because aspirin affects the chemoreceptor in the medulla, and of course there is some gastric irritation as well, which causes some nausea and vomiting. And then due to oxidative phosphorylation, there is more lactic acid production, which kind of eventually leads to metabolic acidosis. And then due to direct stimulation of the respiratory center in the medulla, we see a picture of respiratory alkalosis. And of course, there are direct toxicity signs to the CNS as well. It causes cerebral edema, it causes neuroglycopenia, which eventually leads to altered mental status. In fact, altered mental status is mostly seen in chronic patients as compared to acute aspirin toxicity, and this is an absolute indication for starting hemodialysis. It is very important to start because that actually prevents brain herniation and also life-threatening seizures. And as we know, treatment, there is no antidote for salicylate, and the treatment is mainly focused on alkalinization of blood and serum, and urine. And hemodialysis is recommended to be started early. So, summary, what are the take home messages? Early signs, in fact, early signs such as like tinnitus, vertigo, nausea, vomiting are seen at therapeutic levels. If even as low as like 20-30, you see these early signs. And then hyperpnea, respiratory alkalosis followed by metabolic acidosis, one of the classic signs of aspirin toxicity, and very few conditions kind of show this mixed picture. Regarding the doses, usually they say more than 40 and 50 are associated with severe signs of aspirin toxicity, and in fact, fatal doses are when an adult consumes for around 10 to 30 grams of aspirin. And what are the mortality risk factors? If you see any patient who's old, who's in elderly age, who's tachypneic, or if their diagnosis has been delayed, or if the levels are more than 100, then there are higher chances of mortality. And treatment, of course, if it's an acute ingestion and the patient presents within 1 to 2 hours, and the patient is stable, then you can think of charcoal, using activated charcoal. But in patients with altered mental status, definitely avoid. And as I mentioned, alkalinization and hemodialysis starting on early on together is very important. I know there are studies which basically suggest to start above aspirin levels of 100, but as we saw in this case and many other patients, when you clinically correlate them, it is recommended to start on early on. And this is what I have to offer about aspirin toxicity. If you have any more questions, please feel free to email me at the given email address. And I would really thank you all for putting in these efforts to make this virtual conference successful. Thank you all for your valuable time.